Okay, so our next speaker is Professor Craig Anderson, and Craig, I don't really feel sorry for him, can't be here because he's holidaying in Spain at the moment, but he has very kindly pre-recorded a talk for us. So at the end of this, there can still be questions. Professor Butcher's been dobbed in to answer any questions there might be. Otherwise, Craig can be contacted directly as well. But Professor Anderson is a Professor of Neurology and Epidemiology at the Faculty of Medicine at the University of New South Wales, and is a neurologist with me at RPA. He holds specialist qualifications in clinical neurology and geriatrics, and a PhD in medicine and epidemiology. He's a senior researcher at the George Institute of Global Health, and for many years Craig has advocated for and researched the treatments for haemorrhagic stroke. And his presentation is going to be on code ICH, time for urgency in intracerebral haemorrhage, and is the culmination of much of his life's work. So welcome in spirit. Do I have to do anything up here, or do you guys do it all down there?
Hello, my name is Professor Craig Anderson. I'm a neurologist at Royal Prince Alfred Hospital, and I do stroke research within the George Institute for Global Health, which is affiliated with the University of New South Wales. It's my pleasure to give an overview of a new direction in stroke due to intracerebral haemorrhage, where we have time as a matter of urgency in much the same way as the treatment of patients who present with acute ischemic stroke. And therefore a catchy term that we use is code ICH to indicate it's an emergency. Now the problem for a long time in intracerebral haemorrhage has been this negative view, like the person looking out of the blank window, that there's no treatment, there's nothing we can do, it's such a serious condition, and that often leads to giving up hope. But in my talk today, I want to indicate that there is a bright future. There's a lot of interesting aspects to intracerebral haemorrhage as a researcher that is very good to look for opportunities in new treatment. But for you as patients, a bright future in terms of opportunity for treatment. But there's still a lot to be done. Just to reacquaint yourself of the differences in brain hemorrhage in the brain. Number one here on the left is related to epidural hematoma, which is between the skull and the surface of the brain. It's covered by this dural, tough, fibrous tissue. So if you have a fall, you could get like a big bruise just under the skull base, pressing on the dura, or it could be number two, subdural, which is just below that thick fibrous tissue. So both epidural and subdural, generally because of a head injury and falling. Number three here is subarachnoid hemorrhage, which is below the dura, and there's a thin tissue-like layering around the brain, which is the subarachnoid space area, which can get blood filled within it because of bleeding from a blood vessel, generally a blister or an aneurysm from the blood vessel leading into the brain, which leaks blood into the covering here of the brain. Whereas the most common type of bleeding in the brain, intracerebral hemorrhage, is when the hemorrhage occurs directly because of rupture of the blood vessel into the tissue of the brain. And this is the most serious type of stroke. In our population here in Australia, it accounts for 1 in 10, but in many parts of the world, it can be up to 1 in 4 or 1 in 3 types of intracerebral hemorrhage, because types of stroke, because it's very much related to poor blood pressure control. Now, the pathophysiology of intracerebral hemorrhage, or ICH, is this rapid expansion shown by these sequences of figures here on a CT scan. And that rapid enlargement of the bleeding causes mass effect. And then as a consequence of having this blood in the brain, it can block off the various pathways leading to hydrocephalus, or inflammation, which gives rise to cerebral edema. So we've been trying to look at treatments that can reduce bleeding in the brain, rapid control of blood pressure, or various what we call hemostatic agents, which might clog off the bleeding vessel. There's still research going on in that area with some promising indications. For surgery, it's reducing the pressure, saving the patient's life, and hopefully improving their overall recovery. And there is an indication now that the earlier we can do that surgery, the better. And there's also treatment looking at reducing the inflammation in the brain, but that's really at an experimental stage. Now, in the context of what's happening in the brain and the pressure and consequences of that, we've also got to consider other factors that influence a person's ability to survive and recover from the intracerebral hemorrhage. Obviously, that's less likely if you are very old and frail. If the bleed is very rapid and large, then that's not very good. And often, as you get older, as in other parts of the body, the brain is in less good shape, and other parts of the body from point of view of your heart and the kidneys. And so having a very traumatic event in the brain can make it difficult for the whole body to recover effectively as well, and you're much more prone to infections and clotting within the circulation, which we need to consider in managing such a critical illness. Now, you're aware that for stroke treatment over the last 20 years, we've had a major impact. There's been major advances, major successes. We understand a lot more about how the brain becomes injured. We can map out in great detail the areas of the brain which are affected, and we can understand how best to give treatments to improve circulation to the brain. We now have good systems of care that start in the community, and I'm sure you're all aware of the fast mnemonic, face, arm, speech time to call an ambulance, get to hospital as quick as possible. When you do come to the emergency department, we have these rapid green pathways for your assessment so that we can take you towards the brain scan to rapidly make that diagnosis. And if it's ischemia, which is generally a shadow in the brain, we know exactly what to do now with thrombolysis, clot busting treatment. And if it's a big clot blocking one of the major blood vessels, we can take you to the catheter lab and do a procedure to pull out the clot. And this is extremely effective and can and often lead to a full recovery. But if the brain scan shows bleeding, an intracerebral hemorrhage, there's often a lot of uncertainty for the doctors as to what should we do? Should we do an operation or not? Should we give this treatment, blood pressure lowering? Could we give any of the other treatments or not? And one of the reasons is that we just haven't had the high quality research to give us definitive direction in which to take. I'd like to propose that intracerebral hemorrhage is no different to acute ischemic stroke, that we need active management, and that means we need to work quickly because time matters. Now, I've spent 20 years studying the effects of blood pressure lowering in intracerebral hemorrhage. It's much like pressure in the pipes within your home. If there's a leakage, then it's important to block off or reduce that pressure to reduce the amount of blood loss. Hypertension intracerebral hemorrhage is very common, and the higher the level of blood pressure, the worse the outcome is from intracerebral hemorrhage. It's also readily modifiable. We've got a variety of drugs now that you can use either intravenously to have a quick effect to lower the blood pressure. I've listed here the various levels of systolic blood pressure that we use as a target now. For many years, guidelines have been very conservative. They've recommended a level of around 180 systolic of mercury to control the blood pressure. But even then, that's probably too high, and we should even go lower. There's been 2 big international trials up until last year. Interact 2, which I led with an international consortium, which showed encouraging signals of benefit, and then a US-led study, ATAC 2, was stopped early because of no clear benefit being shown. So somewhere around the 140, 130 mark, it's likely to be beneficial but not clearly proven, and if you lower the blood pressure too low, then clearly that's harmful. And that is why the guidelines for many years have been relatively conservative. These are the American Heart Association, American Stroke Association. They're the most influential recommended guidelines for doctor to use. You can see here in the first line that for patients who present with a systolic blood pressure between 150 and 220 millimeters without any clear contraindication, acute lowering of systolic blood pressure to 140 millimeters is safe. And we grade this level of evidence. If it's class 1 or level of evidence A, that's the highest level, the highest quality. So clearly it's a safe treatment, but when it comes to whether it improves functional outcome or completeness of recovery, it's only given 2A or a level of evidence B, which means probably useful, but not clearly beneficial. And then similarly, if it's very high, again, there's a suggestion that aggressive blood pressure lowering should be recommended, but again, it's not level 1. So for the last several years, I led a very big study called Interact 3, which was published in the prestigious medical journal Lancet last year. And this was to evaluate whether a system of care, what we called a care bundle, which was a component of rapid treatment of elevated blood pressure, hypertension, hyperglycemia, which is high blood sugars, people with fever, and whether they had a clotting tendency or whether they were on a blood thinner, warfarin, in relationship to their intracerebral hemorrhage. In patients who presented with their intracerebral hemorrhage within 6 hours, we worked with hospitals to implement a consistent protocol in all of their patients of active management, treat them aggressively. And this is the schema we used in this randomized controlled trial. We ultimately randomized 122 clusters, that's clusters of patients which were organized within hospital, and we used this design which is called stepped wedge. So the orange here was the control usual care phase, and then hospitals in clusters were randomly allocated to move over to this, to implement this care bundle protocol in their patients. And this was a huge undertaking. These 122 hospitals came from 10 countries, and ultimately we randomized over 7,000 patients. So it was a phenomenal project, and we managed to do this through all of the consequences of COVID-19, kept going, and we got a positive result. And we measure the success of our treatments in acute stroke on a particular scale, which is called the modified Rankin scale, which is a grading of your level of symptoms and physical ability. And it's on a 7-point scale from 0 to 6. 6 down here is that you have died. 3 to 5 here is levels of severe disability. 5 here is bedridden. 4 is severely disabled, needing a lot of care. 3 is some disabilities only need a little bit of care. The 2 here is you have a little bit of weakness, like maybe the arm or leg's a bit weak, but you can still manage your daily activities. 1 here is that you have some symptoms, but otherwise you're well. And 0 is fully recovered with no ongoing symptoms. And you can see that the shift in the distribution of the intervention, the care bundle, all was in direction of benefit. Less deaths, better survival, and less people with severe disability. And we record that as a metric called odds ratio, and anything less than 1 is beneficial, and this was clearly significant, and this was an historic event for us because it was the first time in history that a randomized controlled trial, which is the highest level of evidence, showed a positive outcome in terms of benefit for patients with intracerebral hemorrhage. But even so, even though this research was a care bundle and most people had blood pressure control in it, it didn't clearly show that blood pressure lowering affected the bleeding in the brain and improved outcome. And in another study, which was published in this journal, Lancet Neurology, it was a study of several thousand patients to measure the amount of bleeding in the brain over time. And this probability of ongoing bleeding in the brain is highest within the first 3 hours after the onset of symptoms. So the maximum effect or the maximum risk for the patient after they've had an intracerebral hemorrhage is in the first 3 hours. But in our INTERACT studies and including INTERACT 3, most patients were randomized around 3.5 hours. And so by the time we got blood pressure under control, on average, it was around 5 to 6 hours. So even then, even though we showed a positive effect, we're probably too late. And that's led us to do another big trial with colleagues in China to assess whether blood pressure lowering within 2 hours of the onset of acute stroke administered in the ambulance would improve outcome. And the advantage, obviously, in doing the trial like this in China is there's a lot of patients having stroke. I've got a very good research team there, and we were able to coordinate this in a very efficient manner over the last few years, and we just have presented these results at a big conference in Basel, Switzerland in the middle of May. So you're hearing about these results very soon after they were presented to the world. We undertook this trial over 3 years, completing it last year in 6 regions of China. And the way that ambulance systems are organised there, they have the centralised system, which is very similar in Australia, where you ring a central number from an office within a particular region of the city, or they have a hospital-based model where the ambulance is owned by the hospital, and within that area patients would ring the number for the hospital, and then the ambulance would go out and retrieve the patient, bring them back to that hospital. In China, all of the ambulance staff are doctors. So in the centralised model, it would be doctors working in the ambulance service for that region of the city. And in the hospital-based system, it would be hospitals from the emergency department who would be on a roster to go out and work in the ambulance. And this had a lot of benefits to us because we were able to get a good assessment of the patients, do the research very efficiently. We were able to assess the patients and randomise them into the research project very efficiently, so that we recruited nearly 2,500 patients into this study for this particular reason. And we achieved blood pressure lowering very effectively in the ambulance using a particular drug that we would administer through the vein in the patient's arm. And so the red arm here is the control group who didn't receive treatment. That was not, that's what usual care is. If the patient has had a stroke, they would not receive any blood pressure control until they got to the emergency department. And the level of blood pressure at the beginning on average was 180 millimeters of mercury. And this is the treated group here. We got the blood pressure under control very quickly within about 10 minutes, and we had a very good stable level on the route to the hospital, which on average was about half an hour. When they got to the hospital, which was around here, there was a bit of a rebound of the blood pressure. Obviously, it's a bit stressful being moved off the ambulance into the hospital. Maybe the drug was wearing off a little bit. And then in the hospital over the next several days, there was an attenuation of the difference between the two groups. So the big issue here is that we could get blood pressure under control very effectively, very safely, very quickly on the way into hospital. And that resulted in the proportion of patients who had a bleed in the brain, which was half of those 2,500 patients. And here's the distribution of their modified Rankin scale scores here. The black here is people who died. These are the gradings of levels of disability, and here are the levels of good recovery towards the left here. And you can see there's a real shift towards improved recovery for patients who received early blood pressure lowering. So Interact 4 now convincingly tells us that if you can control the blood pressure very quickly within the first few hours after the onset, moving very quickly, you can control bleeding and improve their recovery. Let me turn now to another controversial area in intracerebral hemorrhage, which is the use of surgery, and this has been around now for 50 years. And traditionally what happens for the surgeon is to do a craniotomy, where we would make an incision in the scalp, pull away the skin, and we would open up the skull, remove a big piece of the skull to expose the hemorrhage, and then go in and suck out that blood and clear it away, and then sew up the incision. This is a very traditional approach. We've used it for a long period of time, and obviously to do surgery is not taken lightly. There's always a complication. There's always a risk of complications from surgery, extra bleeding, and maybe infection related to that. And so we would only reserve it for patients who have a very large hemorrhage, who are deteriorating very quickly, to save the person's life. But generally the surgeons are reluctant to do this because of the seriousness of the procedure and uncertainty over the real benefits for it. Now, this is what we call a meta-analysis, where we pull together all of the randomized controlled trials. And these are the various studies listed down here to the left. These are the number of patients, which are grouped here in the numbers, and you can see they vary quite a bit from maybe just 26 or 36, 124, even here there's maybe 800, 500. So the numbers of patients in these studies vary, and then we categorize their effect on this, what we call a forest plot. These are the individual studies, and the statistics around that effect are grouped on the right, and then we pool these results in the bottom here as a diamond. And anything to the right, which is a better recovery, is shown on here on the listing, and anything to the left doesn't work, it's a bad recovery. And you can see that in general the studies are towards the right, indicating better recovery, but the precision or the reliability of that result, which is indicated by the length of the line through the dot, varies. So when there's a lot of patients, you get better precision. When there's small studies, few patients, you get less precision and uncertainty. And if you pull that together, there is a tendency for benefit of surgery. But because of the high degree of variability in these results across all of the studies, this is not a very reliable result. And there's a statistical measure here that's listed here, the p equal to 0.01. That means it's not a very reliable result. This is for all surgery, all of the randomized controlled trials. It's suggestive of benefit, but not positive. In a subgroup of these studies, which focus on this new procedure, and I'll show you that in a minute, which is called minimally invasive surgery. Again, small, quite variation, generally small number of patients, again, all generally towards the positive, and the diamond is clearly positive towards better functional outcome, and that p-value of heterogeneity is not as bad as on the previous slide, so more reliable, better precision, but again, not definitive. And also in this work, they showed a plot by time to surgery, which is in hours here on the x-axis, and on the y-axis is towards benefit. So higher towards the top on the left is a better benefit, and you can see that according to the plots of the studies, that the earlier the treatment, the more positive the benefit in terms of the patient's functional recovery. So all of this is very encouraging, but it's not positively, clearly beneficial. It's all around that level 2A that I mentioned before, or grade 1, and probably benefit, but not definitive. And so another really important research project published just in April this year is a study of minimally invasive surgery in intracerebral hemorrhage, published in New England Journal of Medicine, and the conclusions here are quite positive, that amongst patients in whom surgery could be performed within 24 hours of acute intracerebral hemorrhage, this minimally invasive hematoma evacuation resulted in better functional outcome at 6 months, 180 days, compared to best medical treatment. And this is the approach they used, is to go through a small burr hole in the forehead and put in a small catheter into the body of the hematoma, represented here on the left, and through both visualization and suction, they could remove all of this hematoma very quickly. There's a variety of devices that can be used to suck out the hematoma, and the advantage of going in and visualizing this through this very small puncture site is that you can stop any active bleeding. You can sometimes the clot here is mushy and even really like hard stone, and you can use a little blade through this endoscope to cut up the hemorrhage and suck it out and clear it out, and do a very good job so that you can really remove pretty much all of the hemorrhage through this small borehole. Now, in other parts of the world, they can use a small catheter with these various fenestrations through it, put it into the body of the blood and flush it 2 or 3 times a day to flush it out. So this one, you don't actually look at the hemorrhage and remove it. You put in the catheter in a well-placed targeting approach, and then you just flush it out over the next 3 days and monitor that with some regular brain imaging to have a very good recovery. So another study from researchers in New York City, they showed with this minimally invasive endoscopic approach that time matters as well. So here is the timing on the x-axis, and this is the probability of a good functional outcome, and it was a linear relationship that the earlier the better. So under the 15-hour period was most beneficial. So things have really changed a lot in intracerebral hemorrhage over the last 12 months. Results of INTERACT-3 with care bundles, organised active management, the ENRICH trial, which is minimally invasive surgery, results announced last year but published in the major journal, New England Journal of Medicine, showing that's beneficial with potential time. And then most recently, INTERACT-4 results showing that early blood pressure control matters. So we are really having to work with our colleagues in the healthcare system to change one's attitude around intracerebral hemorrhage, around active management, and that obviously means we have to, give education, work with nurses, and work with our neurosurgical colleagues to ensure that they have appropriate resourcing to be able to offer minimally invasive surgery as early and effectively as possible in different parts of the world. And, in Australia, we have lots of people in non-urban settings, rural settings, and then who have an intracerebral hemorrhage, and getting them to receive the treatment as early as possible is also a big challenge for us. So let me summarise the findings on intracerebral hemorrhage. Clearly now blood pressure lowering is beneficial. We have INTERACT-4 giving us the proof and the importance of time. I've shown you the importance of time and target-based protocols around physiological control, the INTERACT-3 care bundle, and this should be implemented as a standard of care in all hospitals around the world. We need to go early, and code ICH is a good mantra for us to use. I haven't talked about anticoagulation reversal, thinning the blood thinners. That's an important topic, and that's also important. And I have talked about early surgery, and this is also important. So it's all about a time of change in the management of intracerebral hemorrhage, and the patients who have an intracerebral hemorrhage need to have the same active management and opportunities for treatment and successful outcome as patients with with acute ischemic stroke.
All right, has anyone got any questions? Ken, I think you're up.
What do you plug the burr hole with after an MIS?
Normally glue.
Well, I'm not a neurosurgeon, but as Canadian neurologists have to actually do some neurosurgery as part of their training. And it's been a while since I've seen it, but generally I think it's a wax that you would use to fill a burr hole and fill that over. Yeah, it's if you do a craniotomy, you keep the bone in the fridge, then put it back on months later. But a burr hole, of course, it's destroyed by the burr, so you have to fill it. But they may have upgraded to some type of epoxy or something now, so yeah, it's definitely filled. Yeah.
I actually have a couple of questions, which is really rude, I know. One of the things that Craig talked about was the starting of treatment of hemorrhage with blood pressure lowering drugs in the ambulance. And I'm just wondering, because one of the things you said that is we need to know what type of stroke it is before we start really active treatment.
Yeah.
So if blood pressure lowering tablets was used in the ambulance, is that going to be contraindicated if it was an ischemic stroke?
It is. So for ischemic stroke right now, undifferentiated, we don't actually treat the blood pressure unless it gets into the malignant range, which is 220. We kind of have a double standard there, and we don't apply evidence equally, because if we're thrombolizing you, we lower to 180. And I personally think that anybody with a stroke syndrome in the ambulance, we could do that. We should be at least going to 180, because you don't know what type of stroke it is. You don't even know if it's a stroke. But there's no reason that any human needs to go in an ambulance, needs to have a blood pressure higher than 180, and 180 is known to be safe. Getting people enthusiastic about that, though, is not something I've never managed to convince anyone that that's a good idea, or that, we should do that. So we're in this in-between land right now. The reason Craig did that in China, they had the ambulances there, et cetera. You could do that. In Australia, you got one ambulance in Melbourne, and they've had, I don't know, probably a dozen hemorrhages in 5 years. So stay tuned for another 100 years, and you'll have what they did in China. So sort of the holy, what's that?
They've got a 50% hemorrhage rate, so lowering it's not going to hurt them.
Yeah, exactly. So the holy grail really is to find a way to diagnose, to make the diagnosis in the ambulance. And one of the big differences that the cardiologists have that we don't is they don't need imaging. They can diagnose your MRI, your MI, your heart attack, based on an ECG. And the paramedics do that, and they can send it by mobile phone. And the cardiologist can look at it and go, yep, that's an MI. Please give the tenecteplase, for the online people, in the ambulance. And it's life-saving. It's actually, for people like more than an hour away, it's better than going to the cath lab and having the clot pulled out. We don't have the ECG equivalent. There's no brainwave to tell me that's a hemorrhage, that's ischemia. And we don't have a blood test. That's another thing cardiologists have. They have something called a troponin that says, yep, that's a heart attack. You can go ahead and treat that as well. We don't have a blood test. So people have been working my whole career to try to come up with blood tests that you could do rapidly in the ambulance and make the diagnosis to say that's ischemia, that's hemorrhage. And people have been working on lightweight imaging. And there are some things being studied in Australia. I don't know, am I being cynical? I think we're still a ways off from that. So it's a real problem. And that's why Craig didn't say, he didn't say, yeah, we got to start lowering blood pressure in the ambulance. He said, we've proven that time is important. And that I agree with. Basically, those patients, like all stroke patients, you got to get them scanned ASAP. And as soon as you identify the hemorrhage, you need to start low. That was a long answer to a short question.
That was a great answer, actually. Thank you. My second question is, what are the implications of the sort of treatment for ICH that Craig is talking about for telestroke and for rural New South Wales? Because, again, hemorrhages aren't going to just occur in the city areas.
Yeah, so that I kind of rushed through it at the end there, but what I was showing you is, so in ischemic stroke, all those awards and everything, they're all based on times and metrics for ischemic stroke, the Angels Awards. The reason we hand out those awards is we know what the benchmarks are and we know how people do. 10 years ago, people didn't even measure it. They weren't looking. So with hemorrhage, it's actually, I've spent a lot of time on the telestroke service and elsewhere just trying to convince people, why don't we actually just measure how long it takes us to start a blood pressure lowering therapy and to get that blood pressure down. Those are the targets, and I was trying to show you those benchmarks there. So we've been actually doing that for the last year because Interact 3 was published a year ago, and I think the controversy is over. I think we do need to lower blood pressure. Craig didn't get into it, but it was controversial for a long time. I think it is time to get on with it and do something and not be nihilistic, as he was saying, like staring out into the night sky thinking there's nothing we can do, to try and do something. And blood pressure is one, and the other one is reversal. Now, in Interact 3, he talked about warfarin, which is a drug that we don't like to use very much anymore. There are newer agents, and as of now, we have reversal agents for those as well. So they're coming soon for the most commonly ones. They've been approved in Australia. The paper was just published in New England Journal, I think yesterday. Those agents are available. So the implications for us is we need to measure how quick we treat. We need to treat it the way we do ischemic stroke. We need to have targets. We need to have Angels Awards or something for hemorrhage to try to encourage people, like, we can do better here to help these people.
Any other questions? Any online? Yep, take the front.
There's one over here.
Just bring your microphone.
Yeah.
I actually had a hemorrhagic stroke, and is there another cause for it other than high pressure? And do aneurysms cause it, or could they? And an aneurysm was found in my after my stroke in my scans, and was identified as being not sufficient cause for concern. It didn't grow enough, and but I wondered if that might have been the cause of my stroke. And I might have had, because I didn't ever have high blood pressure.
Right.
Yeah.
So, first of all, there's a bit to unpack there, but Craig, at the beginning, he was talking about the different types of bleeding in the head, intracranial bleeding. So, hemorrhagic stroke, it's almost arbitrary, but it refers to the most common type is bleeding inside the brain. And that's usually caused by a rupture of a very small artery, not even an artery, an arteriole, a tiny blood vessel that has most commonly been exposed to the effects of long-standing high blood pressure over the years. But it also can be affected by another condition called amyloid angiopathy. So that is something that generally happens when you get into your 70s, 80s, 90s. And that's just a protein that gets deposited in those arteries. It's the same amyloid that causes Alzheimer's, but instead of going in the neurons, the brain cells, it's in the blood vessels. They're brittle and prone to rupture, the same as high blood pressure does. So those are the most common causes of what we call spontaneous microvascular intracerebral hemorrhage. There are other causes of intracerebral hemorrhage as well that are called macrovascular. So one of them is an aneurysm. There are other vascular lesions called vascular malformations, cavernomas, these types of things. Sometimes people have tumors or abscesses or other things in the head they bleed into. We call those secondaries. Or sometimes you take a drug that makes you bleed into your brain. Don't take cocaine if you are considering it, or amphetamine. Those things will do that. So, but the most, like 95%, is spontaneous. The majority of it is high blood pressure, and then amyloid. Aneurysms usually cause the other type of intracranial hemorrhage or hemorrhagic stroke called subarachnoid hemorrhage, so bleeding around the brain, which is still a stroke subtype, and actually can lead to complications, including ischemic stroke after that. And I don't know your case, because maybe you had intracerebral hemorrhage and had an incidental aneurysm. I don't know. Or maybe you had a subarachnoid hemorrhage and had another aneurysm somewhere else. I don't know those details, but that's probably as much detail as I can give you without looking at your scans at this point.